in oncology. Please welcome again Ms. Hellin dos Santos, registered dietitian and specialist in clinical nutrition. And Hellin, are you going to tell us about oncology in somehow, which is somehow related to your products, or it's just generally about oncology?
Yeah, I will present background generally, but finish with our clinical research with one of our products.
Sounds great. So,
yeah.
Without further ado, again, Hellin, please tell us about oncology and what we can do with cancer patients.
Okay, thank you. Thank you for this introduction, Professor Clegg. I will share my presentation here. Okay. So talk today about supplementation in cancer patients during oncological treatment. I am scientific specialist of product medical nutrition, so here is my disclosure. Okay. Malnutrition ranges from 25% to over 70% in cancer patients. And we know that when cancer-related malnutrition goes untreated, consequences can be serious. And here, we can see studies that associated malnutrition with loss of muscle, reduced immunity, more infections, lower quality of life, treatment toxicity and complications, and also survival. We can say that malnutrition is directly responsible for up to 30% of cancer deaths. So 3 in 10 cancer patients die due to malnutrition more than to the tumor. Malnutrition is a big problem. So this is a very interesting study because they evaluate patients at first medical visit. We have almost 2,000 patients enrolled, and what they found is that 90% of these patients were already malnourished at the first medical visit, 43% were at risk for malnutrition, and over 40% of patients were experiencing anorexia. And there's another study with patients, but already during treatment, we can find a caloric deficit of more than 1,200 calories daily. Just a minute, excuse me, because I'm gonna mute the microphones. I think I need to stop sharing here. Okay, just a minute. Okay, I'm gonna share again. Okay, so as I was saying, these patients have weight loss before the diagnosis, before the first medical visit, before the treatment. But we need to keep in mind that cachexia is a continuum. So independent of the weight loss, this patient can have reduced appetite. That's why we need a preventive intervention in these patients. We need to act thinking about prevention. But look the results of these studies. Here they are the results from 3 global surveys that were conducted with healthcare professionals regarding cancer cachexia. They asked healthcare professionals at what percentage of weight loss from baseline they consider a patient to be cachetic and then start the treatment. And here the result, 94% of these professionals are very far from the ideal. They only consider this patient cachetic and then start a treatment when the weight loss is more than 10%. And these patients are fighting against the tumor, of course, and the crosstalk, especially in the central nervous system, that cause anorexia and reduced food intake. But they are also fighting against the side effects of the treatment. Changes in smell and taste, nausea, constipation, diarrhea, and so on. That's why we have strong recommendations from POLSPEN guidelines regarding dietary advice and the use of oral nutritional supplements. This is an interesting study because they proved that the more frequent dietary advice limits weight loss and improves energy intake during oncology management. And of course, dietary advice must take into account all side effects, including the taste preference of these cancer patients. But also, it's important to say that the taste preferences of cancer patients change over the course of treatment. So, tastes that were well tolerated before treatment may no longer be tolerable. And it's true for food and also for oral nutritional supplements. Here you can see the influence of taste disorders in the caloric intake of these patients. When they stratify patients according to sweet detection threshold, we can see that those patients with a higher sweet detection threshold consumed almost 600 calories less than those ones with a lower threshold. And it's also true for the bitter, and it's also true for bitter recognition threshold, and not only for calories, but also proteins, carbohydrates, fat, and zinc. And here you can see how the taste disorders also influence the palatability of oral nutritional supplements. So in these studies, they proved that the palatability change for oral nutritional supplements changed before, during, and after chemotherapy. So the palatability can change over time, and it's true for food and for supplements. And so that's why I bring here for you a study. Actually, it was published this weekend, so a couple of days ago. In this study, the aim was to compare the safety and the efficacy of oral nutritional supplement during oncologic treatment. We used oral nutritional supplement high protein, high quality of proteins, unflavored, due to the taste preference of the patients, with vitamins and minerals. Supplement used is Immax, and the patients add and mix Immax with the food of their preference. These patients, the patients included were in an active treatment, so they must have received at least 2 cycles of treatment and would receive at least 1 more. These patients were divided into groups, nutritional counseling only, and the other group, nutritional counseling plus the oral nutritional supplement. And the calories from Immax, the supplement, complete the energy requirements. So let's see the results. Here you can see the baseline characteristics of patients included, the median age of 59 years old, and the main cancer site, colorectal. Now, regarding the efficacy of the oral nutritional supplement, we can see that the calorie intake, considering only food, was not different between the groups. So the oral nutritional supplement did not interfere with normal food intake. What we know sometimes is a myth. So oral nutritional supplement did not interfere this food intake. When we have a look at the results of caloric intake plus supplementation, we can see that only the supplement arm could consume their requirements. So only supplement arm reached ASPEN recommendation of 25 to 30 kilocalories per kilo of body weight, different from the control arm. And again, as I said before, the calories from the supplement completed the requirements, was included in the requirements. So all patients received their requirements equally. The result is the same for protein. So patients from the supplement arm consumed, reached the ASPEN recommendation of almost 1.5 grams per kilo of body weight, different of the dose from the control arm with 1 gram per kilo. Regarding the safety of these supplement, the most common treatment related adverse events were anemia, nausea, vomiting, but they were not different between the arms. So these adverse events were because of the treatment, the tumor, not because of the supplement, as they were not different between the arms. So in conclusion, the use of a high protein, unflavored oral nutritional supplement, here we used Immax, was safe and well tolerated by cancer patients and did not interfere with oncologic treatment. The adherence to the supplement resulted in the intake of enough amount of proteins and calories based on the guidelines proposed to this group of patients. And also another conclusion of this talk, we need always to act as early as possible and use the window opportunity every time we see a patient and can start a preventive management. Thank you.